ladies and gentlemen. Welcome to the Free Market Foundation, and thank you very much for attending today's briefing. I'm not Johann Serfontein, he's about to step up. I'm Jason Erbach, and I'm a director of the Free Market Foundation, and I'm responsible for the Foundation's Health Policy Unit. I had the pleasure of introducing the three speakers today, and judging by the turnout today, I think it's indicative of the quality of the speakers that we have lined up. So thank you for agreeing to come and speak, and I'm really excited about listening to what they have to say, although I think there's a lot of somber warnings that will be thrown in there. Before I ask our first speaker, Johann, to come up, I'd just like to make a few brief opening remarks. I think the debate surrounding national health insurance has become increasingly angry and shrill as the deadline for the submission approaches. And to describe criticism of the national health insurance as scaremongering obscures the facts and the basic economics. So I don't think you need to be someone trained in the economics profession to understand that there's no such thing as a free lunch. And we can predict with a high degree of certainty that free healthcare for all, particularly under a single payer, single purchaser system, will not only cost the country dearly, but will also retard access to poor South Africans. So how do we know this? Well, because we've looked at countless other countries and examined single payer models in other places. And what it tells us is that it's not necessary for the government to provide free healthcare for all, because that's not a particularly good use of scarce taxpayer resources. So you must remember that spending in one area necessarily comes at the expense of another area. More importantly, taxpayers are currently funding the healthcare for those who can't afford it, but to now insist on interfering with the arrangements of those who can afford to pay for their own healthcare is not only counterproductive, but it's unnecessary. So we believe that laws should be judged not on their intentions, but on their outcomes. And we all want good things for the poor, and we want to see better healthcare for everyone. But we know with a great degree of certainty that the proposed national health insurance as it currently stands will have entirely predictable consequences. So we know that it will reduce the quality of healthcare provision in the country. It will drive more professional healthcare personnel out of the country. It will create a bureaucracy that's entirely incapable of handling the huge volume of claims. And it will impose an unnecessary and intolerable burden not only on taxpayers, but on government as well. So if we look at when the NHI fund is up and running, we see that there's going to be mandatory payments into that central NHI fund. And we know that this is going to crowd out private medical scheme coverage, and that's going to have disastrous consequences for access to quality healthcare in the country. We know this because many individuals will simply no longer be able to afford their voluntary private health insurance payments on top of the mandatory NHI payments. And then, of course, they'll be forced to use the already overstretched public healthcare sector. So, and the irony there is that it will actually increase inequality in the healthcare sector because the rich will continue to be able to afford their private medical scheme cover and perhaps hop on a plane and seek medical care elsewhere if the quality is so bad in South Africa. And it will be the poor and the middle class that will be subject to the vagaries of a centrally controlled and administered system. We can tell from the bill, and I'm sure we'll hear from Patrick shortly, that the NHI concentrates power rather in the hands of state officials, and whether directly or indirectly, government will be in control of the availability, financing, and delivery of healthcare, and the choices will no longer be ours to make. How NHI will be funded remains an open question to this day, even after 10 years of deliberations. But one thing is for sure, we know that taxes on an already overstretched tax-paying base will have to increase to fund NHI. So if we look specifically at something like a payroll tax, the consequences of introducing that are once again entirely predictable. It'll be imposed on the formal labor force in South Africa, which means that you'll have less take-home pay, and it will probably result in jobs cuts, and will definitely result in creating another barrier for the currently over 10 million unemployed people from entering into the labor market. So this is not scaremongering. These are the economic realities, and we believe that the solution lies in allowing South Africans to exercise real personal choice and to choose medical insurance that best suits their individual needs. So for many years at the Free Market Foundation, we proposed that healthcare should be treated in the same way as other constitutionally mandated rights, such as housing and education, where the government takes care of the poor and provides financing for the poor, but leaves the private healthcare sector alone. So in simple terms, it should simply finance the healthcare for the poor and let the rest of society decide for themselves where and how to spend their hard-earned cash. Finally, I'd just like to end off by saying South Africans fought hard for their freedoms from an overbearing state. And now the government wants to take over that, and specifically the most personal aspect of our lives, and that's our healthcare, and will certainly undo these hard-won gains that we fought for. So I think we need healthcare that is, or a healthcare policy that does not weaken South Africa's financial health, but leads to better health outcomes for the poor, which is surely what we all want. And on that note, I'd like to call up my friend and fellow Health Policy Unit Committee member, Dr. Johann Serfontein. Please join me in welcoming you to the stage.
Thanks, Jason. Good morning, everybody. We're going to start off today just with a little bit of an overview of what NHI looks like. We do that every time, and every time there's slightly more clarity on where we're going with this. But if one looks at the kind of steps being taken, we're moments away from having an act in place, and so many of these questions remain unanswered. And those are the problems. We've been at this for 10 years. We were supposed to have had a lot more clarity on where we want to go with this. So to look at the NHI funding structure, obviously you're going to have the NHI fund, which is sitting in the middle, that pools all of these funds and it uses it to buy healthcare services. The NHI fund is governed by an NHI board. It will have an NHI authority that administers it. Outside of that will be your benefits advisory committee and your pricing committee, and sort of those structures are not directly inside the fund. You might find the fund sitting in on the pricing committee discussions along with whichever providers there are, and it might be kind of a negotiating forum as well. Then you've got the funding. So you've got your general taxes that they say they're going to be using for that. So that's the personal income taxes they want to levy to fund it. There's the medical scheme tax credits they want to use for that, and of course the provincial equitable share. And then the last one they mention is a new payroll tax. On the provincial equitable share, of course, that currently goes to the provinces, and I think Patrick will probably sort of go into the constitutionality of trying to access that money in a central NHI fund. Then of course the medical scheme tax credit is problematic as well, because if you take those away before the NHI fund is in place, there is research that shows about 1.8 million people will not be able to afford medical scheme cover anymore. So those people are then immediately going to fall onto the state for services, and you'll find that tax credit, even if it does end up in the health basket, it might be for nothing because of all of these extra patients that suddenly clog the system. All of these funds, the origin of all of them, of course, is a taxpayer. So it's not a system like we've got now, where you've got private funds going into medical schemes and taxes going towards the public system. It's all going to be tax funded. Then you've got your various hospitals. So all of these hospitals currently, they're going to be contracting directly with the NHI fund. Currently, they reside in the provinces as far as governance is concerned. Important to note that, all these hospitals are not juristic persons. So they cannot contract with anybody. The contracting happens at the provincial level. So if you move them out of the province, all of these hospitals will need to be made juristic entities somehow. So they will either have to become trading entities or public entities. And both of those means that the employees themselves are no longer provincial employees. They're now employees of the facility where they are. And then you're no longer allowed to belong to the government employees pension fund. I don't think that the unions have picked up on that yet. Otherwise, they probably would have said the thing or two, because you're going to be looking at about 250,000 people being taken off the government employees pension fund and now being employed by these various things. And the government employees pension fund, of course, has a set benefit, a defined benefit, which won't happen if you have a new retirement product within these facilities. So union members and public employees are going to lose those defined benefit, retirement benefits once this happens. And I don't think it's something that has received enough attention. Then you have your districts. At a district level, you've got a contracting unit for primary health care that will contract on a district level. They will be paid by the scheme on some kind of capitation basis there. Of course, the grounding of any capitation model is data. You need a lot of information on who's in any district, what their disease profile is. Otherwise, if you're not sure about all of those things, you could find that the districts are underfunded in a capitation model and they're going to start struggling financially. So we've got a big data aspect that is needed in order to do it like this. Then you've got district hospitals. Now, that's one of the ambiguities that's still contained in the Act. In one paragraph, it says they will contact directly with the NHI fund, and in another paragraph, it says that they will be paid by the district unit. So, I mean, it's just bad law writing, which at this late stage shouldn't have been there. The district will then be having community outreach workers, which will go from house to house, rendering basic services. That's part of the prevention. Then you've got your primary care clinics. They also connect to the district there. And then you've got your private GPs and your multidisciplinary teams who will be contracting directly with the district. There's talk of that happening on a capitation basis as well. In a GP space, that's probably possible. But in your sort of allied health spaces, your ancillary providers, all of those, it's very difficult to bring in a capitation model because it's not a service that everybody necessarily needs, So it's quite tricky to get that right, and one has to look at what other models are there to pay these providers, which simply at this stage there's nothing in place and there's no indication of what it could be, which is concerning because we are very far down the line. Then you've got your district health management officers, which will be involved in the management of all of this. And then you've got your provinces. So currently, provinces obviously are responsible for all aspects of these various hospitals. And under the NHI, the sole thing that the provinces remain responsible for is emergency medical services. And even that, there's a question about it because also in one paragraph it says they'll contract directly with the NHI fund, and in another place it says that they will be paid out of the provincial equitable share. Now, of course, the provincial equitable share is being taken out of the province, so, that kind of ambiguity is in there, and it's concerning. All of these structures, of course, are administrative structures, so there will need to be additional tax funding for the administration involved in all of these. Now, a single funder model, I think one of the reasons they tried to go with that is because in countries like Korea, you could administer it at a cost of about 1%. Now, in South Africa, I don't think that's possible at all. If you look at GEMS, which is probably doing the best of the medical schemes, they're sitting at about a 5% administrative cost. So it's highly unlikely we're going to sit at a 1%. We just don't have that kind of efficiency going in South Africa. And then you've got your private hospitals, so they will be contracting directly with the NHI fund as well. And you've got kind of your private specialists and other people working within these private hospitals that sit there. Of course, one of the big absentees is, yes, there's a mechanism to pay the hospital, and that implies the doctor will be employed by the hospital, but there's no mechanism to pay specialists for any services outside of the hospital. Now, things like psychiatry, you're trying to keep patients out of hospital and they get followed up by a psychiatrist, but there's no mechanism of payment for that at all in the bill. Same with sort of ophthalmology, people that need intravitreal injections. That cannot be done by a GP or a primary care nurse. It has to happen from an ophthalmologist. No mechanism in place to pay for that. So, that's the kind of thing that makes medical professionals skittish, because you're supposed to slot into a system, but there's currently no mechanism to pay you. So one can understand that they feel a little bit concerned. And then, of course, you've got your medical schemes. So those are private contributions, and of course, also your taxpayers. So it's the same people that are contributing there. Medical schemes are allowed to pay for complementary cover, and we'll look at a little bit in more detail about what that entails exactly. So looking at what the government says is what does NHI want to achieve? Basically wants to achieve equal access of healthcare for everybody, and of course free at the point of care. So I think if it sounds like utopia of bulletproof unicorns and perpetually youthful elves, it's because it is. Rob Rose, I think, said it pretty nicely there in an article that was published recently. And when really it's about the how. How do we do this? How does it impact? And we're going to look at the impact of NHI on the various stakeholders a little bit. And these are things that really doesn't seem to be considered. Or, we're all looking at free healthcare for all. But all of these impacts on the various people, including the patients, seem to have not really been thought through, and it's something that are very important. So if you look at the impact on business, cost of labor, if you have to pay additional taxes to get towards healthcare, that'll be an additional cost on labor. And of course, the assumption that government employees, their current medical scheme contributions that get paid by the employer, that somehow that money will be available for use in NHI is also a misnomer, because the unions will not allow that money to be taken out of something that is a package, your package of service payment package for an employee. So they're going to probably demand that money in cash, which means it's not available there. And then probably the unions are going to say, listen, we need more money because we're paying more taxes. So cough it up. Then, of course, just in general, that employer tax that they speak about, that will increase the cost of running a business as well. It's going to be similar to sort of the funding paid over to the road accident, the compensation fund and the unemployment fund. Those kind of contributions might be a straight tax. Drawing overseas talent, in such an environment, is it still possible? Your loss of productivity could be a big problem, because you've got these clinics and the GPs sitting in the primary care level. Clinics currently don't work on appointments. It's first come, first serve. So you can't have a GP in the same system where you can get a GP appointment, which means that you're probably going to have to queue at your GP as well. And somebody that currently at least you can make an appointment and see a GP within an hour, half an hour or something, you'll have to sit in a queue and wait to see a GP. The way a business is probably going to respond to that is to start having in-house primary care services to at least try and keep your employees on the property, but there's a cost associated with rendering that service as well. And of course, if it goes past primary care, your employee has to start at the bottom again in the NHI service. So as much as we want equity, we have to remember that the tax base and the people keeping the economy going need to be able to do that by not sitting in queues all day. The effects on the national fiscus, of course, can dissuade investment. I think that everybody saw what happened with the Discovery share price shortly after the NHI was introduced. Of course, there were some other aspects there as well. But it scares investors, so that's something to take note of. I mean, the hospital shares and those already have been impacted as well. It's probably a bit of a short-term thing, but, it is something to consider going forward. From a medical scheme point of view, the medical schemes are going to become a lot more expensive because, firstly, there's uncertainty about what are they supposed to offer. The intention of the bill, I think, is that they will provide top-up cover. So anything not covered in the NHI service basket, more expensive things will be covered by a medical scheme. But there's also clauses in the bill that says if you skip the referral chain, the NHI won't pay for it, and your medical scheme will be able to cover it. And then further, if you go and look at the definition of complementary cover, which is what medical schemes are supposed to offer, it says that they can cover that complementary cover is anything not reimbursable by the NHI fund. So if you see a private GP who's not contracted to the scheme, it's not reimbursable by the NHI fund, and therefore your medical scheme should be able to pay for it. So I think it's something that crept in there because of a wording change that it used to be they can pay for complementary services, and now it's complementary cover. Subtle little word change, but it has a big impact in that one can read it in this way. And that's why everybody's pushing to just get some clarity on what exactly is the meaning of this. Because if it ends up in that situation, we're exactly where we are now, where the affluent will use their medical scheme to access care at whichever level they want, where the poor will still be stuck with the NHI system, except everybody will pay extra taxes to pay for NHI. So it's a system we're in now, just more expensive. So it's not quite sensible. Of course, if people are going to be paying additional taxes for medical schemes to fund NHI, you might find they might not have money to pay for medical schemes anymore. You're going to have a smaller pool of people that can belong to medical schemes, and that pushes up the cost because your risk pool is smaller. Of course, the number of medical schemes will also radically reduce. And then this uncertainty. There's a lot of talk of saying that the state, might adapt their service basket with whatever money is available. So the question is, if in August the state runs out of money in the NHI system and suddenly medical schemes have to pay for all of those services that are no longer included or covered in the NHI basket, how do they budget for something like that? How do you budget for a basket which you don't know what it looks like? So it's quite a difficult situation. And of course, if this situation comes in, we've got 3 very big healthcare administrators that administer all of the medical schemes, pretty much 90% of the market. What happens to all of the employees in those administrators when the medical scheme industry shut down? So there's going to be big unemployment of these people as well. So it's something to think about. Then you've got your healthcare professionals. What are the effects on them? I think at this stage, uncertainty is the biggest pushing factor for healthcare providers. You know, a lot of them saw the bill coming out and they started making plans to leave. It might just be simply registering of an overseas authority, but when the next shock comes, they're ready to go. But healthcare professionals are investors in their practice essentially. So if there's investor uncertainty, then people don't invest money in practices. And that's why especially young people don't want to open practices because they don't know what's happening in 5 years and they leave the country straight. So it's not a threat from healthcare providers. It's a result of fear and uncertainty in the system. And even if there was certainty, then it would have been a lot better. But people don't want to know, there's no way to know what's happening in 5 years at the moment. Then if you look at things like the 2010 RPL court case, government published a tariff guide which didn't consider practice costs. And based on the fact that there was a process in place where practice costs were submitted and they ignored them, the providers took the government to court and they won the case because government didn't follow due process. So even now, the government can set tariff guides if they go through that process, consider practice costs, and set the tariff. But that is what historically happened. So providers are concerned that going forward, that is what happened in the past. What are the chances under NHI that government considers these practice costs when they're setting the prices for services? So if your practice costs are not considered and you can't keep your doors open, you've got to exit the system because none of the providers see the state as an alternative employer in this setup. And of course, then the cost basis of public and private are radically different. Private, VAT, they have to pay VAT. That's 15% higher than state already. They've got malpractice insurance, which is currently the provinces pick up in the state. Don't know how NHI is going to pick that up. There's no answers on that. Other things as well, rates and taxes, rental, bond costs, all of those are absent in the state setup and they are in the private sector and need to be compensated for. If a provider is forced to go and work in a rural area where there's no proper schooling access for your children and things like that, do you make that shift or do you shift to another country then if you have to shift in any case? And those are the things that are concerning. And then in all of this, employment in private hospitals is probably an alternative, but 54% of specialists in a survey said that they don't want to be employed by private hospitals. So, that would be the impact of something like that. And of course, doctors are quite large private taxpayers as well. So there is a study by RMB that was published the other day that shows, if you have about 4,500 doctors leaving the country in a year, eventually your tax pool shrinks by about 11 billion rand. And that's not replaceable taxes because, any other senior official that leaves the country, somebody else takes up that post and it kind of filters from the bottom. A doctor doesn't get replaced. So those taxes go away and they never come back again. And of course, the biggest problem for doctors is ethical concerns in this whole system. Despite what everybody thinks, doctors are very concerned about ethics when they treat patients. They want to treat patients to the best of their ability. And if you have a specific drug list, if you have a specific protocol and you've got a specific payment mechanism, it could force a doctor into doing things that are not ethically sound as far as they are concerned, because it limits what you're allowed to do for a patient. It's like, listen, you actually need this treatment, but the fund isn't going to pay for it. So, so I can't give you the treatment you actually need. It creates that kind of pressure on people, and they don't like that. From a hospital point of view, what's the impact on them? So there's talk of hospitals that will contract on a DRG or performance-based model, also very vague. And in DRGs themselves, if a patient is more sick for some reason, you could end up losing in that. And it does imply that hospitals will employ doctors. Question then is, will the hospital have to take medico-legal risk if they employ the doctor? Of course, they probably will. So that's an added cost that would need to be considered. The NHI assumption, of course, is that patient numbers will increase. Volumes will make up for the difference in cost, but it will be at a lower rate. So are the volumes big enough to actually make up for the lower rates? Difficult to say. It depends on how empty the hospital is, but it's possible that it might not happen if the rates are different. Then there's the absence of competition law, and I think probably you'll speak to it later as well. But in the absence of competition law, prevailing in NHI as is proposed in the bill, it might well mean that hospital groups might say, listen, let's have a collusive chat here. So if we don't get offered a specific rate, maybe we just don't render services to NHI, and suddenly there's a big problem, and the competition law doesn't apply, so the competition authority can't say anything about it. So those are things that could happen. If you look at big pharma, you know, the big pharmaceutical companies that supply all the drugs, current state tenders are often below cost to the state, because what happens, there's a healthy cross-subsidization from the single exit price that exists in the private sector. So there's a cross-subsidization. The assumption is that if you have a single payer, they can push down prices even further. And that's incorrect, because you already have the same volume of drugs being used either in the public or the private sector. So there's no volume increases in NHI. And then, of course, if the state tender price is below cost, you can't expect that the NHI is even going to get that same price because of the cross-subsidization not being there. So probably your drug prices are going to be higher than the state currently pays. So having a single payer is not going to do anything for bringing down drug prices. And of course, the effect on innovation and investment, you know, it costs a lot of money to innovate and bring a drug into the country. The drive to do that might simply not be there. There's concerns of the government opening up their own drug manufacturing plants, and they've got the key to the patent office as well, so you don't know whether your patents are safe anymore. And then the last thing is, of course, if one of these essential drug list drugs is suddenly not available due to a supply issue of some kind, there isn't going to be an alternative available in large enough scale and volumes to actually close up that space, because nobody has an incentive to produce a drug that isn't on the essential drugs list, because there simply isn't a market for it. So that is something that's going to mean that from a drug availability point of view, we could pick up problems in this model. Then, of course, there's patient access. And I think this is the one that everybody in this room is probably concerned about, being patients ourselves. And the biggest issue there is if you have a limited NHI budget, you could have limited services. If the services in the NHI doesn't at least look the same as that which is currently available in the state sector, is that progressive realization of access to healthcare? Because that's what the Constitution says we have to do, is progressive realization of access to healthcare. If we have a smaller basket of services under NHI because we don't have enough money to implement it properly, is that progressive realization? Even then, if you're able to access it at a private provider where previously only had the state, it's not progressive if you have a smaller basket of services. Rare disease coverage. It's unlikely that rare diseases would be covered. Currently, it takes you a bit of a while, but a patient of a rare disease ends up with some professor at a university looking after them as much as they can. But if under NHI, if you're diagnosed with that rare disease, you're not going to get any treatment if it's not included in the NHI coverage. So you could find a lot of the seriously ill patients with rare diseases that simply don't have access to cover. That primary healthcare inequity will actually remain, because even as it is, your state clinic is mostly staffed by nursing staff, the primary care clinic. The multidisciplinary practices in the private level will have GPs, they'll have physios, they'll have occupational therapists, physiotherapists, clinical psychologists. So already just there, if you register with for private multidisciplinary practice as your primary entry point, you've got a wider range of services you can access straight away than if you register with the clinic. So that is one of the concerns. So, you know, although it tries to create equality, there is this built-in inequality within the system. And then we spoke about those GP appointments and on productivity as well. You'll find the upper middle class will probably still skip the referral chains. It'll be like now, you go see your specialist first, your NHI doesn't pay for it, you've got a medical scheme that pays for it, and you carry on life as usual. So it's very difficult to build equity into a system like this because people with money will always use money to get better access. Very difficult. I mean, it's amicable to work towards that, but to say that the introduction of it is going to absolutely achieve it, one can't say that necessarily. If you look at the WCA patients, or injury on duty patients, they currently get treatment in the private sector because the state services, there were too many delays and things. So if you've got NHI, they'll be back at using those state services and the delays. Looking at sort of the rollout scenarios that there might be for NHI, you probably got the first one that's unlikely to happen is a big bang approach. When we get to January 2026, we say, right, suddenly all state clinics contract directly with either the contracting unit, the NHI fund, medical schemes are abolished, and there we go, boom, the whole system has changed overnight. Tomorrow it works differently. Now, I mean, obviously there's a lot of problems with doing it like that, so it's unlikely to happen. So the proposed alternative that the government has put forth is a stepwise implementation of this NHI fund on a district-by-district basis or a condition-by-condition basis. But even that has concerns, because you could have one district running the NHI model, the district next door running the model that we're sitting with now, and depending on which district has got the better services, you might find patients streaming to the one side or the other side. But it also means that we're running two sets of legislation concurrently, because you need a different set for the one district than for the other district under the NHI. You know, there's no scope in our law system to do things like that. So it's very tricky to say we're going to roll it out on a district-by-district basis, because also the various public facilities within the districts, and it's something Mike will touch on now if you look at the quality aspect, if they don't qualify to contract with the fund, they can't render services to the NHI. So how long does it take to get one district up to there and moving along to the next one? And if same with a condition-specific one, because you could have one condition on the treatment list, and then if it's not on there, how do you access services even at a primary care level then for that condition? And if you need to be referred up into sort of higher levels of care, how does that work? So it's very difficult, and I think the third option is probably what we're going to end up with in NHI in the end, and that is that the state will buy private services from private providers to supplement the shortfalls in the state, and that's probably where it will end up. And what we advise providers is prepare yourself for such a scenario. See how your provider type can render services to the state. How do you contract with the state? And make a plan, make an arrangement so that the state can buy your services for backlogs that exist. Looking at what the World Health Organization says, it says that UHC means that all people receive the health services they need without suffering financial hardship. So they don't say it's not free coverage for all possible health interventions. It doesn't say that, because they do realize that services free of charge is not affordable to a lot of countries. So the idea of a free healthcare for all is a very South African concept. It's nowhere else in the world is there that. And if you look at other single payers in the world, you look at sort of Estonia is one of the big ones. Estonia has only got 1.3 million people, so it's got a small population, and yet, looking at their GDP per capita, it's quite big. So comparing just GDP per capita, the only one of these big single-payer countries that compares to South Africa is Cuba. And if you look at the per capita health spend of Cuba, it's more than twice what we're spending in South Africa. And the South African number there includes the private sector. So half of that is out-of-pocket spend, is your private sector spend. But now, if you look at the interesting thing here is, why does Cuba go so far with their money? It's because they're paying their GPs $60 a month. So it's almost peanuts, So the 11 million people are getting quite a lot for the money that's being spent on their healthcare, because doctors are being paid nothing, and they actually rent their doctors out to other countries. So Cuba makes $11 billion a year by renting out doctors to other countries, and I think we're one of those countries that are renting doctors from them. So it's been named as a kind of a form of modern slavery. So. In the sense, because I know the Brazilian government pays about $4,000 a month for having this doctor in the country. The doctor then in Brazil gets $1,000 of that, and the government takes $3,000. But if the doctor had to work in Cuba, they'd be earning $60 a month. So they're also kind of happy with this arrangement, but they only get the money once they come back to Cuba. So they cannot escape with the money that they earned. Unfortunately, and looking at unemployment rates, and these are old figures. I mean, we're sitting at over 29% now. All of these countries, very, very low unemployment figures. Gini coefficients, a lot more equal than us, and then sort of doctor numbers and things. So, saying that they've looked at other single-payer models, it's not realistic. We need to find a model of healthcare for South Africa that works. We cannot copy anything that's happening overseas, because we are not like overseas. Our disease burden also is difficult. I think we can agree that universal health care is not the issue. The NHI version of it is the issue. Everybody has a right to access healthcare. We need improved equity in the healthcare system that's efficient and of good quality. And I think that a public healthcare service, everybody agree they need to be improved. And access to private healthcare, we need to sort that out. How do we get private government patients to access private healthcare? Because that's what we're trying to achieve. And then out-of-pocket payments must be reduced. And the fee-for-service payment model in the private sector is also problematic. So we need to look at that, and that's why the health market inquiry did their thing. I think in conclusion, the World Health Organization says that UHC needs to be affordable for a country, and already affordable, Michael will look at that, but that's problematic. It doesn't specify free healthcare for all, and it doesn't specify single-payer system. Those are South African choices. And I think when we really look at South Africa as a whole, the NHI model is not the right one for us. And one has to wonder why did we come to this model? And I think the Zondo Commission probably explains a lot better why the single-payer model is proposed than anything else that's available from a research point of view. I think what is needed is we need an honest socioeconomic impact assessment of NHI. Currently, all they did is they compared the status quo to full privatization into NHI, and of those three, NHI is the best. Nobody is proposing full privatization or the status quo as alternatives to NHI, and yet that's what it's being compared to. We need to look at different models of universal health coverage. We need to do a proper actuarial costing. We cannot say that a system is affordable if we don't know what it's going to cost. So we need to get that costing done, like they did in Ireland. Ireland that had an NHI project going. They did a costing and they said, we can't afford it now or ever. Let's scrap it and see what else we can do. We need to get to that point. But we're scared of doing a costing because we know we can't afford it. And we don't want to take that political step. And I think that's a concern. If NHI reduces access due to money shortages, that's not progressive realization. And we need to implement these health market inquiry. The reason for NHI is they say quality in the public sector, costs in the private sector. If we implement the HMI recommendations, costs in the private sector go down. So we need to do that. And we need to overhaul the management in the state sector. I think a lot of the state problems are management related, and those are entrenched managers. So thinking that the Presidential Health Compact is going to turn around the system if the same people are sitting in the management and are expected to turn around a system they've been ruining for 20 years, very difficult to see that happening. And then as a nation, we need to look at alternative and affordable ways of achieving universal health coverage in South Africa and get public sector patients to access the private sector. That's what we need to do. We need to create a model that's unique to South Africa, takes into account that we've got a very small tax base, very high disease prevalence. What do we do in our situation with limited funds? How do we achieve universal health access? We can't take a single-payer Canadian model and think that's the solution for South Africa, because it's not going to work. So I think the debate is too narrow on how do we make NHI work. That's what the debate is at the moment. We need to see how do we get universal coverage going into South Africa, because that's a much wider debate, and we can get a lot more done in that way than focusing all our energy on NHI. Thank you very much.
Thank you very much, Johann. I would now like to call up Patrick Brecher. Patrick is a director at Norton Rose Fulbright. He specializes in financial services, insurance law, commercial transactions, credit law, consumer protection law, privacy law, constitutional law, land rights, medical schemes, and public interest law. His expertise includes highly specialized knowledge of insurance law, and as a senior director in the firm's financial institutions department, his focus is general regulatory commercial work, especially as related to insurance and other financial services. Please join me in welcoming Patrick up to the stage. Thanks, Patrick.
The one thing that all of us would agree with in this room is that we would like a working national health system. It's actually not a debate between the rich and the poor, because I mean all of us in this room, when you get your bill at the end of the month for your contribution to medical schemes that you have, you'd like to have something cheaper and which works. And the trouble is that the government have made this out like wealthy people just don't want poor people to get health care, and it's nothing like that at all. And it's not the question of that if you run out of medical schemes, they use this phrase, you get dumped on the state. It's the very opposite, because while you've had your medical scheme and paid for it, you have taken yourself out of the state and let other people use that tax money for what you're doing. So it's not, and you're not getting dumped on the state because you've paid 8.8% of your tax money has gone into the public thing, and you're now going back to get a little bit of your tax money back. So I don't like this characterization that it's just wealthy versus poor, and we just want to cling to what we've got. If we had a system, I mean, you so often come across people who are going back to Germany when they retire because they've got a good system there which keeps them healthy because they've paid their taxes for years. And that is the start. But what you have here is the single fund. Now, we've just yesterday learned from the Auditor General that there is 62 billion rand of irregular expenditure. Now, who in this room or who in this country has confidence in putting the first tranche they spoke about 250 billion rand in the hands of one minister and that minister's appointees? I mean, do you think that that is workable? And I shared a stage the other day, I won't give his name, but he's a very articulate and clever guy, and we were talking about the health market inquiry, and somebody said, well, what about national health? And he says, I'm not talking about that, it's utter rubbish. Well, I've been asked to talk for 20 minutes, so I can't leave it there, but it is utter rubbish. The other thing is that the expectation being created, I mean, the president was quoted the other day saying that everybody would have national health insurance by 2025. I mean, who told him that? I mean, who told him to say that in public? It's totally impossible. The bill itself says 2026. On a 9-year scale, which started in 2017, and seeing we haven't started yet, it's 2028, 29. So it's not going to happen. And it just illustrates to me that it's become a political tool. There are people, and I'll come back to that, who are going around the country to having public meetings about the National Health Bill as if it's coming in 2025. Now, I'm going to deal today with the constitutional aspects. I always say my favorite book in the world is the Bill of Rights, and it's an exceptional Bill of Rights, and it's more than that, it's the Constitution. And the trouble is, this person who's going to have 250 billion rand of your money hasn't read the Constitution, because there are so many things in this bill which are unconstitutional or contrary to what the Constitution says that it just couldn't have been properly considered. So let's begin, except I can't read it. The first question is the question of concurrent legislation. What the Constitution says, it says certain fields of national endeavour, some of them are for National Assembly and some of them are for the provinces. And health is a provincial matter. But it says that the National Assembly can pass concurrent legislation with the provincial if it's competent under Section 4. And if you look at the second bullet, if the matter can only be regulated effectively by national legislation, and if the matter requires uniformity across the country. Now that typically describes the National Health Bill. So it is something that the National Assembly can pass, although health is a provincial competence. So the National Assembly would pass the bill and then refer it to the National Council of Provinces, who can reject it, accept it, or amend it. Now, the provinces, as I'll show you later, can't accept it because the bill says it's going to take all their money away, which they're spending on healthcare at the moment, to run the provincial hospitals and provincial health systems. And if the National Council of Provinces and the National Assembly can't agree, then it goes to a mediation committee, which is 9 people from the provinces, 9 people from the National Assembly. If 5 of each of them vote in favour of it, then it goes through. So maybe if 2 provinces don't like it, it may still go through, but then there will be a constitutional challenge for the reasons that I'm still coming to. So it's not going to create uniformity across the nation if it's introduced in stages. We've just heard how there's the 3 options, and the only one that can possibly work is to start somewhere and start introducing it slowly. But how do you have a system in the country where some provinces are having their money taken away and getting a bit of national health and other provinces aren't? That is not uniformity across the country, so it's not going to work in that sense. Section 27 Johann's mentioned this, but let's look at it more closely. Everyone has the right to access to healthcare services. The state must take reasonable legislative measures within its available resources to achieve progressive realization of this right. Now, just as a start, I'll just mention the first thing that pops out. Asylum seekers are entitled only to emergency medical services for notifiable conditions. So if you're an asylum seeker, you have anything other than an emergency or a notifiable disease, you can't get service out of the national health. Now look at the very first word on that slide, everyone. It doesn't say every citizen, as a lot of the conditions in the Constitution do. So not constitutional. And it's the same about foreign visitors and the other categories of people who are not somehow in the everyone class. Nor, I say, is it reasonable nor progressive. Now, if you have to have progressive realization, it doesn't mean retrogressive. No, it means that you can't take away my health care that I'm buying from a medical scheme and getting a tax relief in order to do something else, because that's not progressive. That is taking away something. You're supposed to be moving forward. And Johann has explained very well how it doesn't move forward. It just stops everything in its tracks. And I say there are no available resources. I mean, we know that the government is completely insolvent at the moment. We see it every day in the newspapers. There's no available resources with which to do the present bill. And I'm not saying there aren't other things that can be done, and Johann illustrated some of those for us. The most important thing about this bill is that you cannot appropriate money, impose national taxes or levies or duties or surcharges or authorize direct charges against the National Revenue Fund, and it does all of those in the bill unless you have a money bill, and only the Minister of Finance can introduce a money bill. Now, the Minister of Finance hasn't been consulted yet. It says so in the notes at the back of the bill. Now, we're supposed to be putting in submissions by the 29th of November about a bill which is totally incomplete. They said now, I read something this morning from Discovery Health, and I'm sure they're dealing with government all the time and have inside track, that the matter is at the moment in front of the Minister of Finance in order to produce the system according to how we will afford this thing. And until that is done, it's not a bill at all, because it hasn't got the support. It doesn't explain these things. So, and I'll tell you what the implications are that in a minute or two. We are we call it a consultative democracy. The National Assembly, according to Section 59, this is of the Constitution itself, must facilitate public involvement in legislative process. And the next two bullets are what the Constitutional Court has said this entails. The public must be afforded a meaningful chance of participating in the legislative process, and this requires a reasonable opportunity to have an adequate say. Now, if you wanted to read the bill today and you want to make submissions by the 29th of November, which is supposed to be a cut-off date, you can't make meaningful contribution because you don't know how the national health insurance is going to be afforded, because there's no money bill. There's nothing which says that the Minister of Finance is going to allow all the things to happen, which I will show you have to happen before you can fund national health insurance. Now, the National Health Insurance Bill prevails over all laws except the Constitution. Obviously, no law prevails over the Constitution, and not the Public Finance Management Act. So the way they fund it has to be in terms of the existing system. And the chief source of income, besides the contributions that you and I will make when 45, 50 million people register, we'll all be on a register and we'll all have to pay according to your income. You'll pay in advance, and then you get free service at point of service. We don't know what that will cost because there's no funding, so you can't comment on the cost to you to join the scheme in the first place. And they say they're going to appropriate money from the budget, which you do. Everything in this country, and I'll explain that, has to be appropriated from tax money in the National Treasury. But it says it includes shifting of funds from the provincial equitable share. Now what happens is this, every year, and they've just published the latest bill, we get the Appropriation Act every year. And what happens is this, the Treasury says, I've got a pot of money and this is it. And every department and every province makes submissions according to how they would like to get the share of that big pot. And then there's a redistribution according to sharing out, because somebody has to decide how much does education get, how much does police get, how much does drought relief get, and how much does health get. And that gets, all these submissions come into Parliament, the National Treasury draws it up, and then you get the appropriation bill, and it's got long schedules at the back saying, for instance, that the equitable share for health to provinces is, the equitable share, not for health, the equitable share to provinces is 505 billion rand out of the total budget for the next year. And out of that is about 220 billion rand, which goes into provincial health care for running the provincial health service, including the hospitals. Now, so you can't draw money out of the National Treasury unless you've got an appropriation bill passed by National Assembly saying what the equitable share is. And the Constitution says that you have to give an equitable share to the provinces. So you can't shift the money, as it uses the word shifting. It's a very sort of shifty word, in fact. Shift the money out of the provinces who are now using it to pay for the provincial hospital system and put it in the national health insurance system. You can't do that because they are constitutionally entitled to the equitable share. And you can't say, well, go and find money somewhere else, have a provincial tax or somebody on everything and pay for your own hospital. So it doesn't work that way, and it doesn't. The bill is just what are the phrase? Absolute rubbish. You see, Section 57 starts with the obligation to continue with the implementation of health systems. This is Section 57, National Health Insurance Bill, not the Constitution. It starts with the obligation to continue with the implementation of health system strengthening initiatives. Now, that's a good idea. I mean, if they start with strengthening the existing health system and make the provincial hospitals work, and you don't have these people who queue for a day and come back the next day and the next day, and no oncological services in KwaZulu-Natal. Mike, is that still the case? I heard you say that once. And no services and machines which break down. And somebody told me an extraordinary story the other day. It just occurs to me. Somebody, he works with a doctor who works partly in provincial service and partly in private practice. So this guy works in provincial service, and he says he needs a new laser machine. And he does the costing. In government you've got to fill in an order form. Does the costing, and he says it comes to 440,000 rand. Puts in the order form, and luckily a few months later the 440,000 rand laser machine arrives. But he happens to see the invoice. The invoice is for 2.3 million rand. So the 1.9 million rand has gone somewhere else to intermediaries, and that illustrates how you can shift the money, I suppose. But the third point is that, you see, that's not progressive realization. You can't take away provincial services and then put in something else which hasn't happened yet and can't happen for probably 15 years. Now, where do they want to get all this money from? The NHI Bill wants to appropriate the current medical tax credits that medical scheme members currently enjoy. And that you made that point, Johann, that if you do that, there's just a whole big hole in the whole fiscus if you do that. But they say it's about, they said 30 or 37 billion rand is in that tax credit. They take away your tax credit, and theoretically that will go back into the National Treasury, and there'll be a bigger pot of money. And the National Health Fund wants that money, but that doesn't work that way. You can't say that was health money, so I need it, I want it, because you have to go through the appropriation bill and persuade somebody that you're entitled to that money for a system which is going to work. And there's nowhere else that I know of that anybody can take, say, that little bit of the tax money is mine for health until you've gone through the parliamentary process. Then they talk about a payroll tax, which needs the authority of the Minister of Finance. Payroll tax, as Johann said, that's UIF and compensation fund money. You can have a payroll tax, but it's just another cost. You've already paid to join the scheme according to your salary. You have your tax credit taken away, and now you have a payroll tax. And then if that's not enough money, and it won't be, you'll be a surcharge on personal income tax for a specific purpose. Now that's also a unique thing, you see. You're now going to have a tax for the National Health Fund. And that doesn't happen at the moment. There's no such thing, because you pay your taxes, goes in National Treasury, appropriation bill says it goes to X. So you can't pass a law. You can pass a law, but I don't think the Minister of Finance for one moment will pass a law which says, I'm not going to do any more appropriation act for health. You can have that money. It's health money. Because, as I say at the next slide, I mean, what happens about police and education and drought and all the other departments who rush will say, you know, give me a surcharge as well. Give everybody a surcharge, and we can pay for everything. But the tax base might disappear. And then, most extraordinarily, they say one of the funding methods will be when they fine people for contravening the act, they will get the fine money. Now, imagine if you went to the magistrate's court and the magistrate was getting the fine money. The fines would treble. And it's absolutely contrary to any common law principle that the judge gets the money that he's now passed for a fine. So that doesn't work constitutionally or under the common law. And then Johann made the point that it doesn't mean that you get everything, because there are three things in Section 27 which say you can't get treatment at all. If you go to a medical practitioner, they can say there's no medical necessity for this. You're a malingerer, you're a crank, and I'm not going to give you treatment today. Then where do you go? I mean, if the medical schemes have been closed down or taken all their rights away, where do you go to get your basic treatment? From one, you have to register, by the way, with a specific healthcare. You've a specific GP, same as the National Health Service in England. You go and register with a doctor. If that doctor doesn't like what you're saying and says you don't need the treatment, you can't get the treatment. The second thing is that if there's no cost intervention according to a health technology assessment. Now, that phrase isn't defined in the Act. I don't know who does this assessment. You might remember there was a famous Constitutional Court case, Subramani, a guy in KwaZulu-Natal who needed dialysis. And there wasn't enough money to give all the people queuing up for dialysis treatment. And he went all the way to the Constitutional Court, and the province said, we give priority to people who got a better chance. And they said, you, Mr. Subramani, you've been a smoker and you've only got a few months to live, and we're not spending our dialysis money on you. And the Constitutional Court even upheld that as a reasonable decision, because there were people, younger family people who were supporting a family maybe, and had a much better chance of survival. Now that's exactly what will happen here. You'll say, well, look, there isn't enough dialysis machines in your province, so you go away. Now where do you go then? You haven't got a health system. You haven't got a public health system anymore to go to. You haven't got medical aid. And that is not a Section 27 fulfillment of the Constitution. And thirdly, if it's not on the formulary, and Johann also touched on that, the minister and with these advisory committees, and by the way, there are about 8 of them you're going to have to pay for, these advisory committees will develop a formulary. And if it's a rare disease and they haven't thought of it before and it's not on the formulary, you don't get it. So where do you get it? Now, the registration of practitioners is not compulsory. Johann, am I correct in that? I mean, I've read it, and I couldn't. You can't actually make it compulsory, because Section 22 of the Bill of Rights says every citizen has the right to choose their trade, occupation, and profession freely. So you can't say to somebody, you may not be a private practitioner. You can keep yourself outside the system. And I presume, I don't know if this is true or not, but I presume those top Harley Street medical people in London are not inside the national health system. It's if you can afford them and you want the special treatment, or if a specialist has got a 99% or people queuing up for appointments for the next 6 months, why would they want to join a system like this when there are enough people with money to pay for it? So you get this whole skewing of the system. And I read the Discovery Health thing this morning. They also said that there's no compulsory registration for doctors. You can take yourself outside the system, but that's going to create a mismatch as well. So what we've got is a system that cannot be funded on any test in the Constitution. The appropriation bill is not just a law thing, it's a constitutional issue. And we've got a government without money, and we've got a system which can't be introduced in any short time. And I went to a talk, and Dr. Nicholas Crisp was there, and he's an advisor to the minister. He's at Wits University. And he'd flown into that meeting. I don't know if anybody was there at Wits. He'd flown into that meeting from a meeting all day with the minister, so I presume he knew what he was saying. And he was just saying, well, we don't know. When we find money, we'll start doing things. And maybe in 15 years' time, we'll have a system. So he wasn't the one who told the president 2025. But he didn't have any scheme, and he didn't have anything to say about how it would be funded, how it will be introduced, and how you will do a big bang or an introducing thing. So what happens on the 29th is not the last say on this bill, because what you've got there is not consultative democracy. If they try to rely on this submission by the 28th of November, I promise you the Constitutional Court will set it aside and send it back to Parliament. So put your submissions in now, and they said they're going to have public hearings in early 2020 according to the discovery document, and make all these points that you have to make and I have to make them, but it's not your last say, because there's a long, long road to go. Thank you.
Sorry, just give me a second to... Where's this mouse? It's disappeared. Is it? Is that where it's run off to? Mike. Yeah, you are here. Our next speaker is Mike. Mike is an independent consultant specializing in the health funding industry. He's a co-founder of health insurer Zealous, where he served as managing director for 10 years. He specializes in developing growth, stabilization, and management strategies for health funders to achieve growth and superior underwriting performance. He's delivered numerous talks on strategies for sustainable health financing and written extensively on the existing regulatory framework for South Africa's private healthcare system and government's proposed NHI. Michael qualified as an electrical engineer at Wits Technikon and also a qualified certified financial planner. Please join me in welcoming Michael up to the stage. Yeah, always right.
Always right. Good afternoon, everyone. Thank you very much. Yeah, so a deserved monopoly. I wonder, can we answer that question now? Okay, so what I'm going to look at today, SA's public health sector, why competition is essential in healthcare markets, and obviously political influence on the economy, and I think that's quite relevant to where we are as a country right now. For today's talk, I did a little exercise of my own here. I took South Africa's per capita GDP and I pegged it on the far right-hand side of the scale. And I then took all the countries that had a per capita GDP higher than South Africa and stopped at the country that was double South Africa's per capita GDP. And that gave a cohort of 31 countries. And what I then did with that is I said, let's go and have a look at what those countries spend on public health. And all of a sudden, South Africa moves from last to 14th out of those same 31 countries. So in comparison to peer countries that are wealthier than us, we're not shy in terms of spending on, and this is public health, not private, it's only public, so bear that in mind. And it moves us up into the third quartile. So to look at what government's problem statement around healthcare is, this is the same drum that's been beaten by the previous health minister, and it's been carried through here. And I've highlighted the word shortage there, and obviously shortage of doctors. And the reason being given, according to Minister Mkhize, is that this impacts on the number of staff that can be appointed in the public sector. So I thought, let's go and test those claims and let's see what comes up. Now, these are not my figures. This comes from a study, a paper written 2 years ago jointly by National Treasury, an organization called FHR 360, who are an international NGO, and the KwaZulu-Natal Department of Health also participated in this. And what this was is actual employment in public sector, not posts available that are standing empty, actual employment. In March 2006, there were 140,000 medical personnel employed by the state. That jumped to 155,000 2 years later. By March 2012, there was 190,000, and by March 2016, there was just short of 200,000 personnel. A 42% increase in the number of medical personnel working in the state in the space of 10 years. So I kind of wonder where's the minister getting his numbers from, because it has grown. It may not be sufficient. I'm not saying that the ratios, we saw the ratios earlier, but there certainly has been growth in the number of personnel that the state sector can actually pull in. Okay. So let's look at things like outcomes that we're getting in the public sector. One of the two most basic measures are infant and maternal mortality rates. And what I did here is a comparison between other upper middle income countries, South Africa being in that same category. And if we look at infant mortality rates, we are 2.5 times higher than the average for other upper middle income countries. And if we look at maternal mortality rates, we are nearly 3.5 times higher than the average for those other countries as well. So for the money that's going in, seeing that we're spending more than the average per capita than the other countries in a similar category, we're not getting good bang for our buck. And it also shows in terms of the fact that in terms of our disease burden, as measured in something called the disability adjusted life year, which the World Health Organization defines, we rank 19th out of 196 countries in the world. So there are only 18 countries in the world with a higher disease burden than we have. The more effective your healthcare is, the more effective the delivery is, the better you're treating patients, the better the lower your disease burden will get. So we're not doing a good job of it, and that certainly shows in those figures over there. That leads me to have a chat about this organization, Office of Health Standards Compliance. For those who don't know who this is like a clinical auditor general. So they assess facilities. They've only assessed public facilities so far. Under the NHI, it's proposing that they will assess both the public and private facilities that partake in NHI. And the latest report we have was one that was published last year, inspection report that is, and that covered 696 public facilities that they went and inspected. And the officer's scorecard looks like this. On the right-hand side, you'll see there's 6 categories of score there. From the top, which is you're going to get good healthcare, to the bottom, which you better go somewhere else, you're not going to get a good healthcare. And remember, to qualify for NHI, as I think Johann mentioned earlier, you have to get 80% or more. That's your score. Okay, so if you don't get that, you cannot contract with NHI, so you don't qualify. So let's look at the scorecard out of those 696 facilities. They're all public that were measured. Okay. So I think you can see that doesn't really paint a very good picture. As it stands now, 1% of those facilities would be allowed to contract with NHI. So it really poses a question: is this a realistic bill? Because if you're going to go and implement that, you can only contract 1% of public facilities. The rest are not allowed to in terms of the bill. So it doesn't really make any sense in terms of that. The quantum of the figures that we're looking at, though, is very concerning. So we've got 62% there that fall into non-compliant or critically non-compliant. If we look at the provinces, the Eastern Cape, the Free State, and Limpopo, the 2 red components is 80% of the facilities are in those categories. So not a very good picture. And that then leads me to the next point, which is costing the government money. And it's this thing here, Johann touched on it as well. Okay, if your services are not being delivered properly, or there's poor quality, things go wrong, people suffer, then obviously people have the right, Patrick, you would say, to turn to the courts to say, I've suffered, and because of that, I need compensation for that. So the medical malpractice liability is a substantial and growing problem, and it's not really being addressed. This is a bit of a history of it over the last few years. So from 2014-15, it was 28 billion. It's grown to 80 billion. And is now sitting just short of 100 billion rand. Okay. Now, the interesting point about this is almost like Eskom. Okay, it's a liability provision like this is almost like debt sitting on your balance sheet. You don't choose, the government doesn't choose to guarantee this, it just has to guarantee it because it just arises through a court process. Consider that the National Department of Health's entire budget for this current year is 226 billion. So the liability is sitting at 43% of that. Now, obviously, it's not going to all get paid out in 1 year, but it's very much, as I say, like the Eskom debt problem. If that becomes 200 billion or 300 billion, if this is not arrested, then where does the Department of Health stand in that? The money just goes to the lawyers, sorry, Patrick, but but to pay out. I mean, it's obviously not a situation that that can carry on. And this really needs to be arrested, otherwise it's going to turn into a massive problem. So some insider views, we're obviously hearing from ourselves as private citizens, but the Health Ombudsman, I mean, he didn't have very much great things to say. That was quoted as last year. The Auditor General was a little bit more blunt about it, saying that the system's in crisis. And then I think another viewpoint that came out on government's management of healthcare came from the Health Market Inquiry. Now, the Health Market Inquiry was about an investigation and a study into the private sector, but in that study it also looked at how government had regulated the private sector. So in other words, what was government's performance and their role in terms of that, because there is obviously an oversight role that they should be undertaking. So on the Department of Health, they felt that there was inadequate stewardship, I'll put my plastic lips on, of the private sector. Failures not using existing legislative powers to manage, not holding regular reviews as required by law, not holding regulators sufficiently accountable, and because of that they felt that the industry was neither efficient nor competitive. And I'll come to competitive just now, by the way. So overall, there's a really very, very bad picture about how healthcare is being run in South Africa, both in the public sector and in the private sector. So I would sort of come to two concluding questions. And question one is, should government have more involvement in terms of the arrangement of healthcare? And second question is, should they give themselves a monopoly based on their performance? Okay, so it's a very simple question. So that moves me on to a point of this, competition in healthcare and why it's important. The point about bringing this up is that the NHI Bill is creating for itself a monopoly. It wants to own all the healthcare in South Africa as much as possible and crowd out everybody else. And before we touch in terms of some other systems that we'll have a look at, the government rationale for NHI is this kind of in a nutshell. A single payer, i.e. monopoly fund with nationally centralized procurement will reduce costs, and then we'll be able to give more people healthcare. That's the rationale in a sort of nutshell of it. But let's test that and have a look at that. So very often comparison is made with the British National Health System to say this is how single payer models should work, and it does it work. But the British NHS has undergone massive transformation in the last 30 years, and it's not the model it was 30 years ago. At this point in time, funders that exist within the NHS are district health authorities. We also have DHAs here in South Africa. But citizens can actually now start choosing which DHA they want to use based on the quality of the service they get out of them. They're also starting to get patients' choice in terms of their providers. So if they don't like this hospital, or if they don't like that doctor, they don't know if they can choose a different doctor within the system. So what it's meant is that both the funders and the providers have become much more focused on the patient rather than how do I contract with this NHS fund? How do I maximize myself out of it? So it's not become this bureaucratic, it's no longer this bureaucratic system. Money follows the citizen, money follows the patient. So you can imagine if you're a doctor in the NHS, your focus is going to be on providing the best service possible. Incidentally, the NHS also does a massive amount of measurement of data in terms of outcomes. So they also have a lot of data to fall back on, which assists enormously, and we would need to do a similar sort of system if we want to improve outcome. So the essence of it is it created a competitive environment within the state-run NHS system, and the results were improved outcomes, reduced waiting times, and in real terms, costs actually declined in a number of areas. Okay, so the bureaucratic state-run monopoly system, Britain decided 30 odd years ago, maybe even longer, that it wasn't working, and they brought in all these reforms, and these are the results. We can go to the other side of the Atlantic. Michael Porter is professor of economics at Harvard. History tells us that monopolies that are truly benevolent and effective are rare. I don't even think we really needed to know that, because we all know that monopolies don't work, whether they're in the private sector or whether they're in the public sector. But in terms of Michael Porter's work, he's done an enormous amount in terms of healthcare research, in terms of his book, Redefining Healthcare and Creating Value-Based Competition. Okay, and he's also put his money where his mouth is in terms of building this international consortium for health outcomes measurement. More than a dozen countries participating in this now. And this is all about logging the data from the doctors in terms of diagnosis, in terms of treatment, and in terms of outcomes, which means all the doctors who participate in the system are competing with each other because all the data is there. So if I'm not doing so well as a doctor, and I can see I'm right at the bottom of the list, I'm going to try and find out how to get up. And it's not a punitive system because it's peer review, it's open, it's shared, so you can look at how the doctors are treating in terms of getting outcomes up into that system. Okay, so let's get closer to home in terms of some of the rationale. Professor Alex van den Heever of Wits University has been quite a long-standing critic of the NHI and how to, what they're coming up with this. But one aspect here which I thought was quite interesting in what he proposed, what he said here, is that the bill proposes to centralize what should be decentralized. He's not saying like he thinks that's his opinion. It should be decentralized because if the purchasing function is too far from delivery, massive inefficiencies will come into the system. I think he was being kind with the word inefficiencies because I think he knows what he's talking about. I think it probably relates to Zondo Commission or something to that effect. But that's essentially what's going to happen in a structure like that. So concluding questions just in terms of this section here. Should we not rather have a decentralized public structure with regional authority and accountability, and I would add to that competitive forces? But don't we already have that? Because as Patrick was saying, the money goes through from Treasury through to the equitable process and then down into the provinces, down into our district health authorities. So we're actually, what is essentially the way I see this is NHI is a solution trying to find a problem. Because we don't actually have a problem in terms of this. Obviously, the public's not working very well, but it's not the structure that's the problem. It's the actual management on the ground of it. Okay, so political influence in economy. Political influence is a phrase that covers all manner of sins, I would imagine. But and I think we've seen many of them in this country. On NHI, there's been very little, if any, technical or policy analysis on this proposal. And I mean, to have a bill of this magnitude without sort of this depth of analysis work around it is quite concerning. And also the fact that the NHI Advisory Committee has been in place for 10 years. It was established in 2009 by previous Health Minister, Dr. Matsaledi. The only bit of information we really do have verifiable are the NHI pilot sites, 10 of them, but they all failed. They really were pretty much disasters. So the current minister has said, no, they weren't failures, they were learnings. So, yeah. So when you get an F, red F, and a circle around it on your report card, just learn harder next time. So the NHI bill is proposing a complete monopoly, and that's the aspect that I wanted to talk about today. In terms of, I just explained to you how other systems have created more competition within those systems to improve outcomes. Medical schemes are going to be squeezed out. Johann spoke about the complementary system where you can only provide what the NHI doesn't provide. It's quite ironic for me that we have a competition commission in South Africa to make sure that the private sector operates in a competitive environment, but when government says it's going to do something for itself, no, we don't want competition. We'll legislate it out of the way because we don't like that. The NHI bill is proposing total unfettered control in the hands of the minister. Okay, he can hire and fire virtually every key position in the fund. Okay, now that's at any governance level. Even if you ignored state capture process that we've seen with Zondo, if we were in Switzerland or Sweden, this would be a massive problem because this flies in the face of all governance principles. And then alongside with that centralized national procurement committee, that's one of the 8 committees that Patrick also mentioned, is going to be sitting inside the fund. So everything that's procured through NHI sits in this one committee. I'm not going to say anything now because I just think about it. Okay. I mean, if the NHI is a comprehensive package, which I don't think it will be because we just don't have the money, we've got hundreds of billions of rands flowing through the system every year. I mean, even as it stands now, if NHI was to come into effect, at very least the current existing public budget will go through there, which is 226 billion, through this one single committee that's going to do all the procurement for all services under NHI. Okay, so I mean, to me, patronage and corruption will be virtually guaranteed in a system like this, so that's deeply concerning. But what's also interesting for me is the sort of the phrases that are used around NHI by both the minister and many people in the department. It's almost evangelical in its stance. It's magical. It's going to fix everything. We're going to live eternally ever after because once this comes into effect, and I really wonder why. And when we look at political influence, I mean, I only found 5 SOEs that I needed to put on this chart here to to sort of emphasize, and I don't even need to go into any of the details here, but certainly what we don't want is to have a 6 block which says national health insurance on it as well, with the same problems. Just literally yesterday, I think Patrick, you mentioned it, the Auditor General has just said that it's the worst outcomes ever for SOEs in terms of the audit process this past year. So that's very concerning. Okay, so possibilities versus probabilities. Anything's possible, obviously, but I could run the comrades and win, but just unfortunately I can't because of other things. So probability, you're probably going to come towards the back of the field. Bill Clinton got this right in terms of understanding these issues. Economies control governments. Governments don't control economies. Okay, that's a simple fact. Where we are, government debt, I put 60% here plus. I mean, I know it's setting up, but I mean, if it really gets bad, we've got big problems. It's even more problematic in terms of those two figures there, because with the budget deficit sitting at over 6% now and growth at nowhere, we need those two figures to be the other way around to essentially get that debt burden down. It's only going to grow now. And inflation and interest rates remaining stubbornly high as well. Obviously, it's all exacerbated by the constant SOE bailouts. We now see the boxing match at SAA, and we're going to see this will be interesting to see how this all pans out between government and the union. Corruption, we know about the brain drain. We don't even really talk about it anymore, about brain drain, the loss of skills within public entities. But it certainly is a massive issue. And the one I've missed here, in case you were sharp enough, is this one here, which came from Brandon at the business day. So the elephant's not in the room, it's actually head sticking out right through the roof. We can't even see it anymore. And I went to another cartoonist, Dr. Jack, who put this one on over here. And I thought it was quite a good analogy because it's labeled the chainsaw as the NHI, which is what it is, a blunt instrument that's going to cause a lot of damage. Okay, so for me to conclude and wrap up, from 2006 to 2016, we saw that medical personnel employed by the state increased by over 40%. So we had more money, more doctors, but health outcomes did not improve. Now the NHI is saying that if you give us more money, we will give you better healthcare. But they've just proven that that didn't happen. So you really have to question it. Can we afford another tax? I really argue we can't. We certainly cannot afford more wastage of taxpayers' money. And the way the NHI is structured, we are going to absolutely see massive corruption there. My view, the only realistic option is to fix both sectors. But that's not sexy, it's not fancy. You can't sell it to the electorate because you actually have to get down into the ground and go and fix all those problems. That's the only thing that's really going to fix it. Thank you very much for your time.
Okay, we have about half an hour for Q&A. Would you guys like to come sit up here, or are you happy to stay down there? And stay down there. Come. Yeah. So if you have any burning questions, please feel free to fire away.
You spoke about the English National Health Service, and I want to give you an instance which is, it's not unique. If you want to get the average time to get an appointment with a GP is 6 weeks under the National Health in England. My partner's daughter couldn't get an appointment, and they said, you can have a telephone appointment with the doctor. So she waited 2 days, and the temperature was rising and rising. In the end, she phoned back and said, where's my appointment? So then the doctor phoned back and said, no, it's no problem. You just got to do this, this, and this. This is over the telephone now. Yeah. And she ended up with a temperature of 41, had to go to the emergency care, which they told her that she definitely cannot do. Now that's supposed to be one of the better systems in the world. And I compare the average skills within that sector and look at the skills that we've got within this sector, and I can only see another SOE debacle.
Does anyone want to comment on that?
I did have a case the other day where somebody needed a hip transplant in the public sector. They said, come back in 4 years.
And I know Mike's done some calculations for accessing dentists under NHI.
Yeah, I mean, we've got a massive shortage of dentists in the public sector. So, I mean, I think we worked out roughly that on current numbers, if dentists were fully booked for 11.5 months of the year, it would take about 15 years for them to get back to the same patients.
Yeah.
So the numbers are just not there.
Yeah, look, even in these big single payer that were there, you know, in Estonia, it takes you 4 years to get cataract surgery. In Canada at the moment, you can get an MRI done for your pet much sooner than you can get one done for yourself. So that is kind of one of the big things in all of these single payer systems is the waiting times, because you've got to ration services. There simply isn't enough services. If you're offering something at no cost, then people take it up like crazy. And then if you look at some of the other systems that there are, you know, sort of Taiwan and those places, they've got massive co-payments. You know, in Taiwan, you pay co-payments up to $2,000 a year in co-payments. You know, if you go to see a doctor, you have a co-payment. You know, so all of these services, there's always co-payments involved. So having one in South Africa where there's absolutely no payment whatsoever, yes, we need that because we've got a lot of indigent people, but it does create that problem of people trying, you know, people just grabbing what they can.
Yeah, I think the other point to make is that the GDP per capita in real GDP per capita is 4 times greater in the British system, and the unemployment levels are nowhere near. So that they have a much bigger tax base, and if you're seeing a situation like that arising where these massive queues are coming up, you can only imagine how long it's going to take to access care in the South African situation. So that's a huge concern. Gerard, I think you were next. Did you have a question?
No, I'm not.
Sorry, it was behind you.
Okay. I thought I'll use the opportunity since I was confused with somebody else, but that's fine.
I'm just puzzled that apart from the quotations of Mkhize, the Minister of Health, could the Free Market Foundation not find one person to say anything positive here about the NHI?
Well, I think the big elephant in the room that's protruding out at the cost. So, I mean, that should be the end of the argument. We should really just, exactly how the Irish system worked, just fell on its sword. Once you've done an actuarial calculation of what it's going to cost and what the medical, bureaucratic personnel required to run a system like that, that should really have been the end of the argument. And it really reveals the situation that this isn't based on any kind of economics, but is purely a political and ideologically motivated event where they just don't want to see the private sector operating more, and I think that's the simple truth.
I think, I mean, if we are looking for something, I think I could add, I think the new minister is more engaging with the private sector than his predecessor. I think it's slightly encouraging that there is at least a committee now that they're engaging with. Obviously, it's only just sort of been constituted, so we'll obviously have to see what the outcomes of that are. But yeah, I do think it's slightly better from that perspective. I think the previous minister was quite dismissive of the private sector and always just loved to heap blame onto it. Yeah, so there are some things. Let's see.
So the answer is no, there's no one to say anything positive.
You have to look in government for somebody to say something positive. They're very positive about this because they're driven by the ideology and not by the practicalities.
They're not driven by the ideology. I can tell you why they're driven, and take that example of the laser machine from 400,000 to 1.5 million. That's the ideology.
I think I can have a lady.
Hi, my name is Kim. I'm a psychiatrist, so excuse me if I don't talk anything but doctor. I want to just check in with something. I was actually a registrar when the Liphosidimeni crisis happened. And psychiatrists, when things scream and shout, we tend to sedate rather than speak. But at that stage, we actually spoke a lot. And I don't know if you must have heard about the Liphosidimeni, where all our patients just died, and some are probably still dying, and who knows how many. There was no accountability, actually. There was a bit of money, and some patients' families got all nicely compensated for, so-called. But my question really is twofold. First of all, are the correct people hearing this? Because I'm hearing it and I'm writing down as many things as I can. But the people that actually, end of the day, make the decisions? Are they hearing this? Are they actually hearing it? And secondly, what can we do as a little psychiatrist sitting up the road in Randburg, and I'm scared, I've got a young family, I've got aging parents, what can we do as a citizen and as a healthcare provider to actually have our say to this government that is now supposedly listening? I'm just wondering what we can do.
I must say that it's been a problem all along, because any healthcare system should be doctor focused. Doctors should be guiding government on how do we want to deliver healthcare, and that process has been absent. I think the Department of Health has simply not been engaging with the doctor societies on this, and that's why I think every society needs to have a look and see what can we do right now, the small things, to make it better, and propose those to governments, because you can, as much as we can engage with the NHI Bill, the fact that it's probably not going to happen means that all of that comment is just going to go to the wayside. So look at practical solutions. What can we do right now that we can try and get the health system better, try and get access to state patients into the private sector, and create a mechanism to do that. That's probably the best one can do. And perhaps one of the things that needs to happen is private providers need to say, listen, everybody's willing to donate an hour of their time a day to see state patients pro bono. And you would find that that would give massive access to the private sector for state patients. You need somebody to administer that, so let's get Discovery to donate their time to administer something like that, or one of the other providers. And then the hospitals can donate beds and things if necessary from their part. And you can find that one can go a long way if you do it like that. And people, the will is there. Private providers are willing to do that. Most of them are. But there's no opportunity and there's no system in place to do it.
What can you do as an individual? I think one of the things that you can do is attend sessions such as this, so that you're armed with the intellectual ammunition to actually move the needle on public opinion. So get involved in debates, and we've at the FMF have certainly found that one of the most efficient ways of achieving our objectives is to get involved in public debate and go onto radio stations and debate the minister and say, look, these are the concerns that we have, but always provide a solution. So what is the proposed solution to the problem? And Patrick mentioned one of the ways: do a submission, okay, and make yourself available for oral evidence when you get called. But I think the most important thing is to arm yourself with the intellectual ammunition to push back against some of the ideas.
How bad is the disparity? Sorry.
Sorry, can I did say this gentleman
Sure.
was there. Sorry about that.
Sorry. I have a practical proposal. We should ask every politician supporting the scheme if he is ready to accept medical care under the scheme. Then he has to say yes. And then we send them to the non-performing institutions. That will kill them, and then the NHI Bill is killed.
Sorry, I don't actually know. How bad is the disparity of skill between public and private? Because the answer we keep saying is we need to give access to private quality. But we have doctors in public, so how bad is that disparity, and why can't we move them?
Yeah. I don't think it's a doctor quality aspect. It's everything around it. It's whether the doctor has the medication they require. It's whether they have the bed they require, whether the bed has linen. I know somebody was speaking over the weekend about the registrars at Baragwanath looking at projects where they can improve service delivery. One of the groups, their project is, how do we get the porters to arrive at work? That's their group project, because the porters don't rock up. And what happens then is you've got a doctor that's trained 10 years that has to walk around fetching patients at the ward so he can operate on them. So all of those so there's a whole systemic kind of thing. The skills are in the state sector. That's where specialists are trained. That's where all your doctors originate from. But the state can't keep them because they don't fund all the posts that need to be funded. And then, the work circumstances are just such that people eventually get tired and they go. And so from a skills point of view, that's equal. There's no problem with skills at the public sector. It's everything around it. And the fact is, if you can get the private sector involved, it's just about getting higher levels of getting those patients on the waiting lists to get quicker care. That's all that would be about.
Can I say, behind it all, interestingly, the latest appropriation bill came out yesterday, and under the heading NHI, the funds that are called NHI, is creating more posts in public hospitals and buying linen and beds. So there isn't, NHI money is not going into this non-working thing for at least 3 years. So the whole thing is just a sort of long-term. And the other thing, can I just say something else? At the same time this came out, the National Health Market Inquiry came out, and that was lots of good ideas about reducing costs in the private sector. But that relies on exactly the same funds that I was talking about as the NHI bill. They both want tax money and bits out of the National Treasury. So the country's got to decide whether you're going to try and go into, that was a five-year endeavour to produce that report. And good ideas, but there's no funding for it, there's no legislation for it, and there's no Minister of Health who said anything about making legislation for it.
I think the big difference between also the NHI and the Health Market Inquiry is the underpinning. The Health Market Inquiry did a lot of underpinning research to come to the conclusions they came to. So they actually looked in detail at those things. That's largely absent in NHI. We've been at it for 10 years. You can't get research out of them on why did you decide on a single payer model. That kind of thing, it's just not there. And to try and get underpinning research in place to create a service basket, we've been trying to add primary care to the P&B basket in the private sector for 3 years now. That's how long we've been at it. We still don't have a base basket. We don't have a basic kind of indication of what's going to be in there, and that's after 3 years of work. It took us 8 years to establish the current P&B basket as it is. So thinking that between now and 2026 we're going to have a service basket in place for NHI is just not realistic. So that underpinning research is largely absent, and we need to get that done, because if you don't have that, you can't even realize that it's not possible to do all these things. Because you just believe it is, and there's nothing saying it isn't, because you're not doing the necessary research.
Look, the good news is, from what I hear, it's not going to happen. I mean, these guys simply won't get it together. And in my world, the stuff that I'm doing, we're taking government to court on stuff, and we win every time. And somebody said to me years ago, and we take them on technical matters, and we win every time. And somebody said to me, at some stage they're going to get it right. And I said, they never get it right. and as we progress, they're getting further and further from getting it right, so it's getting easier. So this is the good news. So my question is, there will be a constitutional challenge at some stage. Okay, then I can go to bed and I forget. And people ask me, what do you think? I say, it's never going to happen. They just don't get it. They will just not get it right. Because these guys can't think it through. There's no ambition. There's nothing to benefit from this thing. So it will die. And at some stage they will lose interest and go into some other socialist venture. And this is what's going to happen as long as there's guys like these sitting behind us and says we'll challenge that every time. Then I think we can go to bed and leave it to these three guys and say, that's fine. The thing is in good hands. Nothing is going to happen. But work as hard as you can, and we'll help you to,
I think you're right from a point of view, but that only satisfies a small section of the population. Because the problem is for poor people who can't afford private.
No, but that's good. But that's a different focus. I'm talking about this particular venture.
I agree with you, but I'm saying it's if you are in that category of citizenship, you're looking at your government saying you're spending all this time and money on a hopeless thing that's never going to work. Can't you spend that same amount of time and money on actually coming to the hospital and getting the equipment working, getting the linen on the bed. These are practical, simple things, but it's just the focus is not there, and that's quite sad, I think.
And it's also the opportunity cost, right? So now we're sitting in limbo, and people are anticipating national health insurance coming, and you're not going to have massive investments so a practical example is what Johann referred to earlier. You've just come out of specialized. What are the chances of you actually sticking around? Because you don't know what's going to happen in the next 5 years. You're certainly not going to set up a practice that costs massive amounts of money. So maybe different for different specialties. So an anaesthetist might kind of stick around, but someone like an ophthalmologist or someone that has massive costs in establishing their practice, they're going to go, well, I'm just not going to stick around. And now, every single time someone like that disappears, it worsens your health outcomes. So, and that's just one aspect of it. So the thing is the opportunity costs and the lack of investment. We're just not seeing that investment coming in, and people aren't going to pull out because that's really going to look bad on them, but they're just not investing in setting up new facilities. They're not expanding. They're not going to do any of that because they don't know what's going to happen. And that's very difficult from an economics perspective and an actuarial perspective to claw that back over time. So we've been sitting with this situation for at least the last 10 years, and people are just sitting on their hands, and predictably. Why would you want to sink money into a country where it's going to be nationalized, the healthcare sector? Sorry.
Can I just add to that point? It's not just the fact that the doctors are saying, okay, let's go. Health more than anything, you touch people on their health, they say, I'm not prepared to go into my old age when there's a possibility there'll be a ruinous system. So your tax base is going to go. And it's almost like shooting yourself in the foot. You want this enormous amount of money for a healthcare system that won't work, and your tax base, the main contributor to your tax base is finding health outside of the country. Health services outside of the country. And what concerns me more than anything about, we also don't think that it's going to work, but one of the things that's concerning is the perception is likely to be worse than the absence of reality. And the perception is not.
I was trying to think of the name of an organisation. It was going back 25 years ago. I think it was called Prime Cure Clinic. And I used it, and it was very efficient. It was very low cost in comparison to the other privates, and also the medicines as well, because they're buy in bulk. I'm not quite sure whether it failed because of the model, or if it was bought out because it was competing too effectively with the private sector. I don't know if any of you know it, but what comes to mind now, I have to quote Winston Churchill, and he said, "A country trying to tax its way out of poverty is like a man standing in a bucket and picking himself up by the handle."
Do we have any other questions? Yes.
One of the stakeholders that is not featured, especially in the patient access, is people with disability. And I would love to hear your views or your insights of anything you can add so we can actually add it to our submission. We're going to write a submission on the 29th. Where that will come, I do not know, and I'm hoping that this one will end, but in the meantime, we need to submit a submission. Please add, all of you.
Look, I definitely think that people with disabilities are a vulnerable group, and they have a lot of comorbidities a lot of the time, according to, and there's access issues. You need to be able to get to a clinic, and it's a lot more challenging if you're in a wheelchair because firstly you can't properly get into the taxi. So it already, it really is very challenging for people with disabilities to access healthcare services as it is. Whether NHI is going to fix that is highly unlikely, unfortunately. They might be able to then start accessing private services, which would be nice. But there's all of these underlying funding issues and things like that. But there's a very real danger in anybody with a disease that's relatively expensive to treat, and a lot of the disabilities are like that, is that it simply won't be covered in the basket of services because it's too expensive. And you then find that, I still can't figure out whether if you have a disease that's not on the treatment basket, whether you can at least go to a private GP and get pain control, or whether you're not going to be able to have any access whatsoever. So you might not be getting anything that can treat your disease, but it's not certain whether you can get something that will just make it, from a pain point of view or something like that. There's no clarity, and what we need at this stage is a lot more clarity on what people can expect, that service basket. We need that because you need to know that so that you can do a costing. And that service basket can also not be smaller than what is currently available in the state, because then it starts getting regressive again. So we need to cost the current state system so that we can see what does it cost us to render these services. Because remember, we know what we spend on budget for everybody, because we say, okay, it covers 50 million people. But not all 50 million actually get treatment. So we don't know what it costs an individual patient to go for treatment at a government clinic. We need to have a costing at that level so that we can say, right, so that's the cost of treatment at a clinic. What does it cost to get the 20 million people every year that does require treatment? If you need to give that to all of them, what's it going to cost us? But that kind of, it's simply absent. And so we need to cost the services we're currently providing in the state service, and then go from there and say, okay, so this is what it costs us to treat a patient. We can effectively, we had 15, 20 million patients, let's work it out for all of them then and see what. Then you can start talking and say, okay, but actually, this is way more than we're currently spending, so we can't afford that. What can we afford and what do we need to do? But that thinking is just not there at the moment.
Can I just remind ourselves that Section 9 says, of the Bill of Rights, says you can't discriminate unfairly on the ground of disability. So if the formulary didn't cater properly, that would be challenged, because it's a basic constitutional right under the Promotion of Equality Act.
So if the bill passes as it currently is, what's the low-hanging fruit from a constitutional court challenge?
Well, the money aspect is the biggest hole. It's just non-starter.
Okay. Just one behind you, Kurt, and then you next.
All right. Just want to ask, what is it that makes the private medical aids at the moment quite costly or quite expensive? Is it because there's usually a narrative that says it's due to the oligopolistic nature of it, or is it due to the regulatory burdens and tax burdens?
Well, yeah, so definitely there's a regulatory failure. What happened when they initially introduced PMBs and all of those is that there was supposed to be, they took away risk rating. So medical scheme doesn't charge you more because you're sick or old. So they took that away, and they took away the right for medical scheme. Not you have to accept the person that applies, you have to accept them. What was supposed to go with that was that they wanted to make medical schemes mandatory, and they wanted to do a risk equalization fund. So those two aspects of the scheme industry were never implemented. If you do a risk equalization fund, you spread the risk across all schemes equally. And if you then make it mandatory for everybody to be employed to join a medical scheme, and if you can mandate the minimum wage, then you can mandate medical scheme membership. It's quite possible. It would actually reduce the underwriting costs for everybody by 20%. So you find that the entire scheme industry becomes 20% cheaper overnight by simply introducing that. But they don't do that. So that drives up costs. And then the care models themselves, unfortunately, fee-for-service incentivizes people to over-service patients. So one has to look at alternative reimbursement models as well.
Both of those are dealt with national, the health market
but
inquiry.
you don't need NHI for that, though.
Yeah.
And then obviously the PMB. So, I mean, the open enrollment and the PMBs are a list of prescribing and benefits that every single medical scheme option, irrespective of which one you're enrolled in, has to provide. And those alone cost about 800 Rand a month at the moment. So that's immediately blowing out the low end of the market from accessing private medical scheme cover. But it's essential to have as large a number as possible participating, because then from an actuarial perspective you can work out exactly what, or you can work out in a much better way what your expected health costs are going to be for that pool. So I mean, the one thing is, at least at the low end of the market, exempt people from prescribing and benefits, so that we can try and get as many people who can afford to pay for their own healthcare out of the public sector into private healthcare, and then the government can focus its scarce taxpayer resources on the truly destitute. At the moment, it's just paying for people who may be in a position to actually afford their own private medical scheme cover.
If I could comment on that, it was an actuary at Insight Actuaries about 4 or 5 years ago, did a study on exactly what Johann was saying, is if we had this complete regulatory framework, estimated costs would be about, private sector medical scheme contribution costs would be about 30 to 35% cheaper than what they are now. So I mean, the HMR has been emphatic about it. The regulatory framework is inappropriate. We need to fix it. And that is a big factor in costs.
Okay, Gerard?
Is there sufficient awareness and participation from civil society. The normal guys that's paying for these funds are they very much aware what's happening?
Yeah, the number of submissions that I can't remember who it was, but it was announced recently how many submissions they got. If I remember, it was 100,000.
Yeah, so I think the majority of those are simply, no, I don't support NHI. It's a kind of a tick box exercise. But the fact is, it is an indication. On the other side, of course, you've got the public participation process where everybody's in support of NHI. So it's kind of an equal, depends on how informed you are and who informs you, whether you oppose or love NHI. And that's unfortunately the thing, because it's very easy a lot of the time to label people who don't support NHI as being anti-people, anti-healthcare. There's a lot of labels, they come and go from time to time, but that's one of the problems. And it's very interesting because even the people that support NHI, you'll see they say, we support NHI wholeheartedly. We just have these 25 concerns, and then, if you take out those, there's actually not anything left that they are supporting. So it's very interesting that the way that is framed, is that people start with, I support NHI wholeheartedly, I'm a friend of NHI, and then there's this list of things that, they're kind of concerned about. And it's, it's not actually a good debate, because if you've got that many issues, you can just say, listen, this isn't going to work, I don't support it. But, everybody has political considerations, unfortunately.
All diplomacy, I think.
Yeah, I still need to read that book.
Okay, are there any more questions? One more.
Just a comment. I actually happen to be a civil worker, and part of my job is to go around looking at our public hospitals and to see what the qualities are, especially just here in Gauteng, and we often find that they're mostly non-compliant and all of that. But going back to Johann's point, I mean, the doctors in our public services are they're good. We even hear instances where some doctors in the public services are consulted from the private hospitals. But the issue is that when you look at our hospitals, on the facilities point of view, is that they're not well maintained, and you find some systems are very old. Also, like the administration is just quite poor. And you get all of this long waiting lines, etc., etc. Yeah.
So I think, just to conclude, I think there's that famous adage, when things are in the hands of the state, they're in a hell of a state. So I think that sums up what you just said nicely. Thank you very much. Please join me in thanking our speakers for today.